Hey, so if you're a nurse or a nursing student who's been looking for a really clear, no nonsense guide on how to manage acute mania, well, you've come to the right place. Today, we are going to break down the essential clinical playbook for what is honestly one of the most challenging situations we face in mental health. To really get why this matters so much, we have to start right here with the patient's own words. This is how one person described being in a manic state. Think about that for a second. Trapped in the madness of your own mind. It's such a powerful reminder of the storm that's happening inside, and it's exactly why our skilled, empathetic care is so absolutely critical. All right, so first things first. Before we can jump in and help, we have to know what we're looking at, right? The foundation for any good nursing care here starts with understanding the different flavors of the bipolar spectrum. Getting the context right, well, it sets the stage for literally everything that comes next. So, what's the real difference here? Well, it all boils down to severity. Bipolar 1, that's the big one. It's defined by having at least one full-blown manic episode. This is the kind that causes serious problems in someone's life, and often it means a trip to the hospital. Now, bipolar 2 involves what we call hypomania, kind of like a less intense version of mania, but it also comes with major depressive episodes. And then you've got cyclothymic disorder. Think of it as years of these highs and lows that aren't quite full-blown episodes, but they're chronic and they still cause a whole lot of distress. Okay, so you've got a diagnosis, or at least a strong hunch about what's going on. What now? Well, your number one job when you hit the floor is assessment. You have to know precisely what to look for, how to spot and even measure the symptoms of mania, because that's what's going to guide every single thing you do. One of the absolute classic signs you're going to see is this right here, flight of ideas. The source material I was reading had this perfect analogy. It said if normal speech is like water coming from a garden hose, the pressured speech that comes with mania is like a fire hose. It's just so much, it's fast, it's loud, and it can seem totally all over the place as the person jumps from one idea to the next. So how do we move from just, our gut feeling to some actual objective data? We use tools, and this is a great one. The Altman Self-Rating Mania Scale. It's a really simple 5-question scale that helps us quickly get a number on the severity of the symptoms. And, just as important, it lets us track how a patient is responding to our care over time. And this number right here, this is the magic number you need to remember. A score of 6 or higher on that Altman scale, that's your clinical cue. It's a big, flashing sign that strongly suggests mania or hypomania is present, and it tells you that a much deeper assessment and some immediate action are needed, like right now. Okay, and that brings us to the heart of this whole thing, the playbook. This is what you actually do. When a patient is in the middle of an acute manic state, your interventions have got to be direct, they've got to be targeted, and they have to be laser-focused on safety and getting that person stable. And this table just lays it out so perfectly, doesn't it? It's basically the ultimate study guide format. You see the symptom on the left, you get the targeted nursing intervention on the right. Is the patient hyperactive? You reduce stimulation. Are they not eating or drinking? You offer high-calorie finger foods and drinks they can have on the go. The goal is always to tackle that underlying physiological risk first. Now, how you talk to your patient is just as important as what you do for them. Think about it. Inside their head, it's total chaos. Your consistency, you are their anchor. So you use a firm but calm voice. You keep your sentences short, simple, to the point. And whatever you do, do not get into an argument or get pulled into their whirlwind of ideas. You are providing the structure and the control that they've temporarily lost. So as we're working to stabilize the patient, medication is obviously key. And you just can't talk about mood stabilizers without talking about lithium. It's an incredibly effective drug. It truly is. But, and this is a huge but, it is a high alert medication. It has a super narrow margin of safety that every single nurse has to understand and respect. This number, burn it into your brain, 0.6 to 1.2 milliequivalents per liter. That is the therapeutic blood level for lithium. That tiny little gap between this range and a toxic level is exactly why we have to be so vigilant with monitoring. It is absolutely non-negotiable. You've got to know how to spot toxicity, and it's not just one thing, it's a progression, so think of it in stages. Below 1.5, yeah, you're going to see some expected side effects, but as that level starts to creep up, that's when the alarm bells need to ring. You start seeing that hand tremor get coarse instead of fine. You see more GI upset, confusion. Those are your red flags. That's when you withhold the med, you notify the provider, and you intervene before it gets to the advanced or severe stage, which is a full-blown medical emergency. Ultimately, patient safety depends on great education. And these 3 points, these are your absolute non-negotiables for discharge teaching. Consistent fluids and consistent sodium are vital. Why? Because if the patient gets dehydrated or their sodium drops, their lithium level can shoot up into the toxic range. The bottom line you have to teach them is this: anything that makes you lose a lot of fluid, a stomach bug, sweating a ton in the summer, is a reason to stop taking the lithium and call the doctor. Period. All right, so the crisis is over, the patient is stable, but our job is far from done. The whole focus of our nursing care has to evolve as the patient moves from that acute crisis phase into the long-term maintenance phase of their recovery. I mean, just look at the difference here. The acute phase, that's all about putting out the fire, right? It's immediate safety, injury prevention, medical stabilization, meeting those basic needs, like food and sleep. But once that fire is out, the goals shift completely to the future. The maintenance phase is all about relapse prevention. It's about education, it's about making sure they stick with their meds, and it's about building the coping skills they're going to need to live a full life with a chronic illness. And that really brings us to our final and maybe the most important question. Our role is so much more than just managing symptoms during a crisis. The real art of psychiatric nursing, it's collaboration. So beyond the clinical playbook, you have to ask yourself this: how can you empower your patient to go from just being someone who receives care to being an active, informed partner in their own recovery journey?